Again, I have to start? No. Huh? Again. Okay. Okay. Good morning, students. I don't know whether you've heard the first part of what I've been talking about IDSP. I will repeat. We are talking about Integrated Disease Surveillance Project today because of its renewed importance. So, this has assumed renewed importance. Sorry, I'm not able to put it on the. It's taking all the modes, but. So anyway, if you are able to see my screen, then you will know we are talking about IDSP. I'll just enlarge this a little bit. Still not working. Please give me 2 minutes. Still not working. Okay. Maybe you're able to see my screen. So okay, so we are talking about IDSP or Integrated Disease Surveillance Project as it is called. So this was launched sometime back in 2003 by the Government of India. So almost a decade back it was launched, more than a decade now. Because of various emerging and resurgence of various diseases for which the government's required to keep a very close watch on what is happening to the trends of the disease. So, surveillance in its true terms is called a watchdog, which means that it's like a watchdog who is watching every movement which is happening with the related disease in question. So, it is trying to find out through surveillance. We try to find out which disease is increasing, which is decreasing, which has formed a plateau, and our interventions are not working on those diseases. So, on the numbers, on the trends, on the mutations or newer strains of certain diseases, we try to keep a watch through the surveillance. So now this surveillance can be at various levels. They can be at the local level, they can be at the district level, at the national level, even at the international level. So we have diseases like polio which are being watched very closely at the international level, because polio is a disease which is targeted for international elimination. So even if there is a one case, suddenly the entire international governments, they jump in and then they take the appropriate measures to control that one case of disease, so that spread does not happen to the other diseases and it is controlled then and there. So that is disease surveillance project, and we shall again quickly revise which are the diseases which are due for surveillance. Now, why I am saying this is this has assumed greater importance is because of the COVID-19 pandemic. Initially, international governments were trying to look at the trends of diseases, look at the trends of zero prevalence and zero conversion, right? How many people were getting better and all these things. But now, with the emergence of the new strain, the UK strain, or you can say the mutant strain of COVID-19, again, IDSP has assumed greater importance, because now we have to track the movement of the people, the entry of the disease, a new strain in various countries, how many people does it affect, to study the epidemiology, and also to understand the numbers which are associated with this disease, so as to determine how severe the new mutant strain is. So that is why I thought you could be updated with the IDSP, and we could take it up for a quick revision class. So if you see what is surveillance, okay, try again. No, this is not working. So if you see what is surveillance, surveillance is the systematic collection, analysis, interpretation, and dissemination of health data on an ongoing basis to gain knowledge on the pattern of disease occurrence and potential in a community, in order to control and prevent disease in the community. So you can see that surveillance, as I told you in the very beginning, if even if you don't remember this complicated definition, if you just say that it is to keep a watch on the trends of disease or the patterns of disease which is happening in a community, you won't be wrong. Okay, so why we do surveillance? Because there are so many diseases which are described or amenable for control. Some are amenable for elimination, eradication. Okay, and then to study the outbreaks of other diseases which are happening from time to time. So what is this control? Definition of control is when the disease prevalence is less than or equal to 1 per thousand population. So then we say that this disease has ceased to become a public health problem. It is not a public health problem anymore, and the numbers are well below or equal to 1 per thousand population. Okay, so then it does not remain a public health problem anymore. So we say the disease is controlled. Then when do we say that the disease is eliminated? Okay, when the disease prevalence is less than or equal to 1 per 10,000 population. Okay, control is 1 per thousand, elimination is less than 1 per 10,000 population, and then we say that the disease has been eliminated from that community. Eradication is a greater term, which means that the disease has been removed from a larger geographical region or a region of political jurisdiction. Let us say the country of India or the country of United States. So the disease has been totally eradicated or wiped out from the country, and there is not even less than one prevalence. Okay, so disease will no longer it will occur in that particular population. That is signified by the term eradication. So three terms: control, elimination, eradication. Control, less than 1 per thousand, elimination, less than 1 per 10,000, and eradication, the disease ceases to exist in that population. Then a definition of outbreak has been described for surveillance, which is somewhat synonymous with epidemic definition. So here when we surveil, then outbreak, epidemic, all these things almost mean the same word for us. So sometimes it is a preferred word, because if you say the word epidemic, suddenly there is a lot of attention, international attention, as to what is happening to the disease. So that is why we say that there has been an outbreak of cholera, there has been an outbreak of Japanese encephalitis. So in a small population, in a small scale, if that disease occurs, then we call it an outbreak. So alternatively, a localized word as opposed to a generalized epidemic. So whenever the disease occurs in a localized area, okay, like gas poisoning or so many different things. In a small scale they happen, they do not happen all across the country or all across the state. If it is larger in its extent, you know the definition of epidemic, it should clearly exceed more than 2 standard deviation of the normal pattern of the disease, then we call it an epidemic. And also it reflects the geographical area which is affected because of the epidemic. Okay, so outbreak is for a smaller area, epidemic is for a larger area, and pandemic is through many, when many countries of the world are affected. So these are some of the components of the surveillance activity. You may have read them in your book. It begins with collection of data. When we collect data, then we tend to compile it under various headings, okay, and this compiled data is then subjected to analysis and interpretation. So we look at what do we analyze. We look at how many cases have been there last year, how many cases are there this year. We analyze according to age groups, okay, what is happening in the lower age groups, what is happening in the extremes of age groups. We can analyze according to gender, what is happening with males, what is happening with females. Okay, so all these things show us a trend. Okay, how are we able to say that COVID is more severe in the elderly population and in the children compared to the adult population? Because surveillance data showed us some trend that it is the older people who are dying, okay, and the young kids who were not dying and who were not getting affected. So we said that okay, COVID does not affect younger children, but they should be safe because we don't know what is going to happen to them. So few case studies kept coming now and then that it presented with some severe forms in the children, but it led to increased mortality. Again, when we had mortality data, so we subjected it to surveillance. We collected mortality data as surveillance data, and then when we analyzed and interpreted, we saw that the elderly who had more comorbidities like pre-existing heart diseases or kidney diseases or lung conditions, they were more likely to die due to COVID compared to healthy elderly. Okay, so this is how Sentinel, our surveillance data can show what is happening in the community, and we can derive some worthwhile or logical conclusions from all this data. So when we have these logical conclusions, what do? We follow it up with some public health action. Okay, so this action can be at various levels. It can be educating the people what is happening, so they are aware of the trends of the disease. It is rising, it is falling, who is more likely to be affected. All these things can be described. Okay, then you can launch some preventive program. It is, if it is on a very large scale, like the government said that we have no, this is not going to be controlled by the population. Education alone will not help, we have to completely lock down. So that was a political intervention to stop the disease or control the disease, or preparedness plan, whatever you can say. Okay, at many levels the government intervened, but then they lifted the lockdown, they educated people on social distancing and masking and so many things. So this was all the follow-up action which followed the surveillance activity about the trends of COVID-19 in the country. And finally then they received feedback that how many people are following, how the disease is getting controlled. And on a day-to-day basis, I think between March and September, almost till the month of September, we kept on receiving reports on a day-to-day basis on as on how many cases are there, how many recovered, how much mortality is there. Still we are receiving it in the news channels. So that is the kind of feedback which can be generated from surveillance activity. Now because this is a pandemic situation which where all the countries on a very high alert, so we are doing it on a day-to-day basis and people are being informed. But for other diseases like let's say polio, malaria and all these diseases, they are also under surveillance, but we do not receive day-to-day reports of such diseases. So we can receive monthly reports of such diseases, and we study the disease trends in the population for such endemic diseases. Okay, so the steps are collection of data, compilation, analysis, follow-up action and feedback, and further collection of data. Now, what information are we getting from surveillance? Okay, basically it's the epidemiological information. So we try to answer these 5 questions. Who gets the disease? How many people got the disease? Where did they get the disease? Why did they get the disease? So when we get our answers to these 4 questions, under who, we describe the population. Okay, under how many people, we describe the numbers, and we can also describe these numbers by ages and genders, by occupational groups, by physical activity groups, and so many things. Okay, so who gets the disease? We describe the population in detail. How many got the disease? So we put the numbers against everything. Where did they get the disease? Is basically you can describe the geographic location where the disease is prevalent, whether it is an urban disease, whether it is a rural disease, or if let us say it is localized to a certain geographical area, let's say South India, North India. So where tries to answer all these questions, and you try to localize where the disease is prevalent. And finally, why did they get the disease, tries to answer what went wrong. Okay, so there might be multiple reasons. Don't think only about the host factors. There are several environmental factors, there are several political factors, there are several social factors which can let's say which are involved in the causation of a disease. So when we try to answer why did they get the disease, then we understand the complete picture: who, how many, where, and why. And then finally, when we have this entire data and information in our hands, we can decide what needs to be done, so that we are able to target some part of the intervention or some part of the control measures towards which are directed to answer each of these questions. So this is the information which is generated from surveillance, and it helps us to decide what needs to be done. Now, when the IDSP was launched, I told you that it was launched in 2003. So that time it was seen as a rationale for launching for IDSP that there were some limitations of the existing mechanism of surveillance at that point of time. And some of the problems are listed here. First was data collection system was overburdened. Okay, so we had a limited number of healthcare workers in the field, and they were overwhelmed with data collection. They had to collect data for so many different diseases, maintain so many different registers. You know very well what are the different registers or data sheets which are maintained by the health worker male, health worker female. So they are the grassroots level workers who are responsible for the entire data collection. And now with the launch of NHM, NRHM, ASHA has also come in to contribute to some of this data collection. So it was an overburden to collect data for each and every disease separately. Then second was the quality of reporting questionnaire, where the questionnaire was not strong enough, or it did not provide information on all aspects of the disease which surveillance is expected to provide. Then third problem was poor data transmission. Again, before the launch of NRHM and before the launch of Health Management Information System, HMIS, the data transmission was very poor. Wherever the source of data generation used to be at the level of the primary health center, and data used to remain there, it was not transmitted until the monthly meetings, and that again remained at the discretion of the let's say medical officer who is attending the meeting, which data to transmit, which data did not to transmit. And you might understand when you become PHC medical officers that within the limited time frame of those meetings, it is very difficult for the medical officer to transmit each and every data, and to describe and discuss each and every data that he is receiving. So now but now all these problems have been resolved. Under the IDSP, we have a well structured let's say health management information system, where all the data is fed in a computer at the PHC level, and it can be visualized at various levels. Whosoever authorities are interested at the higher levels also, they can have access to the PHC data. So such mechanisms have been put in place to take care of this limitation. Okay, then there is lack of integration of surveillance system in various disease control programs. You are very well aware that there are so many control programs. They all operate in isolation. Okay, so there is malaria, there is filaria, there is TB, there is AIDS. So they are there is RCH. There nothing is linked together. So they all operate in isolation. And when we talk about data collection person, that is one of the reasons why he is so overwhelmed. He has to collect data on dengue, on malaria, on vector-borne diseases, on waterborne diseases, on this, on that. So that is why there is no integration. Okay, so once he visits one family, he should be able to obtain the complete information about that family. There was no such format in the beginning, but now it is there. Okay, then there was incomplete coverage because private sector was not included. Then there was lack of data analysis because data used to remain in the PHC itself. It was never transmitted to the higher levels. So nobody knew what is happening. Okay, then non-communicable diseases, which were not much of an emerging problem 2 decades ago, they were not considered at all. So all the data was collected only for vector-borne diseases, for infectious diseases, let us say TB, HIV, and the diseases of this sort. Hypertension, diabetes, they were slowly rising, but nobody cared to collect any data at the grassroots level from them. Okay, then there was a problem of timeliness in data transmission. So data which was collected, let's say today, was transmitted and put into use after 3 years, after 5 years, when a compiled report was prepared. So it did not lead to any action. And you already saw in the let's say our steps of or components of surveillance, that analysis and interpretation should be followed up by action, otherwise the purpose of surveillance remains unfulfilled. Okay, so these were some of the mechanisms which were limiting the surveillance at that point of time, which and thereby the need for integrated surveillance was felt. So initially it was launched in November 2003 as a 5-year project, and the main change in the surveillance program or project, which was a landmark change in contrast to the existing surveillance activities, was that it was a decentralized state-based surveillance system. So initially, whatever surveillance system were in place before 2003, they were all national surveillance systems. So the center identified some of the diseases and they told that, okay, we need data on these diseases, and the states they worked very hard to collect that data and send it to the center, and they waited for the center to respond, which sometimes happened and sometimes did not happen. So for the first time they made it decentralized. They said that each state will identify what are the priority diseases in addition to national priorities, and then they will act themselves at the state level. So it was intended to detect early warning signals of outbreaks and to initiate an effective response in a timely manner. Because we something happens in let's say Hyderabad, and we cannot expect the center to suddenly jump in and initiate an action. So state decides whether it is a high priority disease, how much priority should be assigned to that particular disease. Let us say so many diseases followed those flash floods in Hyderabad. So we do not expect the center to jump in and understand what is happening to those diseases, but we can always wait for the states to respond to such outbreaks. Okay, so the goal of IDSP is to ensure that each member state has the capacity to define, detect, and respond to communicable as well as non-communicable public health threats. Okay, so they can define, they can have their own definitions, they can have their own mechanisms for detection, and they are able to respond to communicable as well as non-communicable diseases. So what does this yield, this goal? Or what are the strategies for achieving this goal? First is there should be timely, complete, regular, and high quality information which should be collected at all points of time. Second is from these informations, we should be able to detect and predict the epidemics early through the early warning systems. Okay, and right now I will tell you at the end of the class what is the early warning system which is being issued by the government for the mutated strain of COVID-19. So then there is objective assessment of interventions during the epidemics, and finally it should lead to effective monitoring of the intervention programs. So these are the strategies which ensure that the member state or the states have developed the capacity to define, detect and respond. Okay, so first is define. For definition you need information. For detecting you need detection and warning systems and assessments, and for responding you need to launch the interventions and then to assess whether or monitor whether the intervention is working well or not to control the disease. Then we have aims and objectives. The aim was to establish a decentralized state-based system of surveillance for communicable as well as non-communicable disease. Objectives were to improve the efficiency of existing surveillance activities of the disease control programs and facilitate sharing of relevant information with the health administration, community and other stakeholders so as to detect disease trends over time and to evaluate control strategies. So basically it was not only to generate information and keep it to themselves. The first objective was they should be able to detect what are the trends of the disease, and finally they should also be able to evaluate what is happening with the control measures for that particular disease. Okay, so these are some types of integration which were listed in the integrated disease surveillance project. First is sharing of surveillance information of disease control programs. Okay, second is developing effective partnership of health and non-health sectors. Third, including communicable and non-communicable disease. Fourth, effective partnership of private sector and NGOs. Fifth, involving academic institutions and medical colleges into disease surveillance. So you see, wherever there is data related to any communicable or non-communicable disease, it could be government sector, it could be public sector, it could be NGOs, it could be private sector, it could be academic institution. So everywhere they have tried to develop a partnership, even with the non-health sectors. Okay, so even the non-health sectors, they are saying that partnership should be there, and let's say from the women and child department under the ICDS scheme or any other such scheme. Okay, so so they are trying to develop partnerships so that they obtain information from each and every sector in the community, and the information is complete. Now these are the diseases which are targeted for eradication. I'll just zoom in a little bit. Okay, so diseases which are targeted for eradication or elimination at the national and international level are poliomyelitis, neonatal tetanus, measles, diphtheria, leprosy, guinea worm. Guinea worm has already been eradicated out of all these. Okay, so poliomyelitis, neonatal tetanus, measles, diphtheria and leprosy. So now you can probably understand why so much, what are the actions which have been taken against the diseases which are targeted for elimination or eradication. Poliomyelitis, international commitment is there. Neonatal tetanus, governments are let's say pushing people for 100% institutional delivery so that the risk of neonatal tetanus is minimized. Measles, now as a mop-up campaign, MR vaccination campaign has been launched. Okay, so people are working very hard to contain these diseases or wipe out these diseases from the face of the earth. Leprosy, again, major initiatives. Diphtheria, major initiatives. So these are some diseases which are targeted for elimination, and they find mention in the National Health Policy also. So when you read National Health Policy, you will see that the names of these diseases will appear. Then you see epidemic prone diseases. In this, we have avian influenza, cholera, bacillary dysentery, plague, meningococcal meningitis, viral hemorrhagic fevers, yellow fever. So these are the diseases identified in 2003, and now the list has expanded with the emergence of new diseases. So these are some of the epidemic prone diseases which are regularly surveilled and information is supplied to the higher authorities. Then diseases which are a major public health problem. Okay, we have not been able to control these diseases very well. So that is why continuous data on what is happening and how the programs are working are needed to understand these diseases better. So first is diarrhea among under 5 children, pneumonia among under 5 children. Now these two diseases together are the major killers of children under the age group of 5 years. So a lot of commitment is needed to control these diseases in the under 5 age group. Then we have HIV/AIDS again, which has international commitment. Malaria is a disease which we have not been able to control over the years. It is a major vector-borne diseases affecting millions of people in the country every year. Tuberculosis is one. Onchocerciasis or river blindness is something. Trypanosomiasis or African sleeping disease is also one of the diseases, vector-borne diseases, which is a public health problem. So these are some of the problems which were identified at that point of time, and they were included in the list of diseases which were to be surveilled or closely watched. Then components. So what are the components through which the surveillance happens? First is establish and operate a central level disease surveillance unit. Second is integrate and strengthen disease surveillance at state and district. Third is improve lab support. And finally, you have to provide training for disease surveillance and action also. Okay. So these are the components for IDSP that you will probably see in your books. So what did they tell the states? They said that you surveil a limited number of health conditions and risk factors. You have to strengthen the quality of data analysis and links to action. You have to improve lab support. You have to train the stakeholders in disease surveillance and action. You have to coordinate and decentralize various surveillance activities, as well as on one hand you have to decentralize, on the other hand you have to integrate disease surveillance at state and district levels and involve communities and stakeholders, including the private sector also. So I showed you a picture earlier, this one, where the arrows point towards the integration. So various levels of integration are public, private, NGOs, medical colleges, and all health and non-health sectors. So everything has to be integrated so that complete information is obtained about a disease. Okay. Now, what are the expected outcomes of all these activities? They are expected to simplify the recording and reporting. Information is more accessible and timely. Action is more appropriate and timely, and resources are used more efficiently. So these are some of the diseases. I think you have this list of diseases, but you see that apart from infectious diseases like malaria, acute diarrheal disease, typhoid, measles, polio, there is also other conditions like road traffic accidents. Okay, so they have a link up with police computers. Now police is a non-health sector. Okay, so that is how we meant that they have to integrate with the non-health sectors also. So this is a very clear example of non-health sector. Okay, then unusual clinical syndromes like meningoencephalitis, respiratory distress, hemorrhagic fevers. Okay, and there is further STDs, and then there are certain things which need prevention or promotion of health, like water quality, outdoor air quality in large centers, and then there are periodic surveys for non-communicable disease risk factors. anthropometry, physical activity, blood pressure, tobacco, nutrition, blindness, everything is monitored. And then because this is a decentralized program, states have been given the authority to decide which are the state priorities, and they may add up to 5 additional conditions for surveillance. So in the state of uh, Andhra Pradesh, we have acute flaccid paralysis, we have neonatal tetanus, we have diphtheria, we have leptospirosis, we have anthrax. So all these diseases were in this one, Andhra Pradesh, and lymphatic filariasis was also there. Okay, so these are how states have been given the power to decide what will be there in IDSP. So now then look at the classification of surveillance in IDSP. There can be a syndromic diagnosis, which is diagnosis made on the basis of clinical pattern by paramedical persons or members in the community. There can be a presumptive diagnosis of disease, which is diagnosis made on typical history and clinical examination by medical officer. And finally, there is confirmed diagnosis, which is clinical diagnosis made by medical officer or positive laboratory identification. Now, though they have been listed as SPL, in reality they move as LPS. Okay, so first few cases which appear in the community are subjected to confirmed diagnosis. Once diagnosis is confirmed and the doctors and community understand that this is the kind of clinical picture that we are going to see in all subsequent cases, then they say that we have made a presumptive diagnosis of so and so disease, which is made on typical history and clinical examination. And finally, when there is no doctor, community themselves are able to make a diagnosis. Oh, this is the kind of thing which happens with this particular disease, so probably this is the disease. So it is also called syndromic diagnosis or probable diagnosis. Okay, confirmed, presumptive, and syndromic diagnosis. So these are 3 definitions for diagnosis which are used in the surveillance. Okay, then there are various levels of response, rapid response teams. Okay, on the first trigger, there is a response by the health worker at the ground level. At the second trigger, there is outbreak investigation response by the PHCs, CHCs. At the third trigger, there is outbreak response by district surveillance unit. Then at trigger 4, epidemic response by state surveillance units. And fifth is disaster response by the central surveillance units. So these are some of the things, if you remember in IDSP, you will be able to write IDSP well. You should know what are the diseases which are included in the list for Telangana. So now I am going to tell you that an advisory or SOP was for surveillance and epidemic response for the new strain of COVID-19 was circulated on 22nd December by the Government of India. So you can find this on the Ministry of Health and Family Welfare website. But what I am going to read out for you is certain points in relation to IDSP. Okay, so SOP for surveillance by state and government, by state governments under the IDSP. All contacts of those travelers who arrived at various airports between 21st and 23rd December and tested positive would be subjected to institutional quarantine in separate quarantine centers and would be tested as per ICMR guidelines. Okay, so this is number 1. Then list of travelers traveling between 21st and 23rd December who are found RT-PCR negative at the airport shall be shared with the respective states and the central unit. They shall be advised quarantine at home and tested as per ICMR guidelines. So this is the second level when they test RT-PCR negative anybody who is traveling from UK. So we are at this stage now. You know, the government of Telangana has said that testing will be done in the airports, and if they are negative, they have to be quarantined at home. Then those international travelers from UK who arrived in India from 25th November to 8th December will be contacted by the district surveillance officers and advised to self-monitor their health. Okay, if anyone amongst them develops symptoms, they will be tested by RT-PCR. So this was the existing guideline at the time of COVID-19 also, and for the new strain also, similar kind of guidelines are being followed to see how the disease erupts, how people who are who were negative are suddenly coming back to India, and will they develop any symptoms or not, which are the age groups who will develop symptoms, how long after the travel are they going to develop symptoms, so that will determine the time of exposure and the time of infection. Symptoms they will be able to see. Okay, then the list of international travelers who arrived in India between December 9 to December 23rd will be shared with respective state and district surveillance officers for daily follow-up till 14 days after their arrival in India. So this is the period 9th December to 23rd December, that is the third and fourth week of December, when maximum number of cases started showing up in the United Kingdom, and that is when the alert was sounded in the UK and people started moving out. So that was the period of high infectivity within United Kingdom, and any person who was exposed during that period of time in the United Kingdom would be followed up very closely upon arrival in India also. Then passenger will be provided following advice during first visit or contact by healthcare provider. You will receive daily calls or visits from the state health officials. You are requested to self-monitor for development of symptoms suggestive of COVID-19. Okay, in case you develop the symptoms, isolate yourself at home, put on a mask immediately, and inform the district surveillance officer or contact the national helpline. District surveillance officer has to ensure daily follow-up of passengers under observation for 28 days. Now, initially it was 14 days, now they have to follow up for almost a whole month, 28 days starting from the day of arrival. So, similarly, so many clauses are listed here, and then those who test positive, they will be subjected to genomic sequencing so that they identify the strain and how it has mutated, or is it the original strain or the mutated strain that the person is affected with. Now, there are some guidelines for the contacts also. All the community contacts of the travelers who have tested positive would be subjected to institutional quarantine. Okay, so they cannot remain quarantined at home. They have to go to quarantine centers, and they would be tested between day 5 and day 10 as per the current ICMR guidelines using RT-PCR. So all these things have been notified by the government of India for COVID-19 new strain control. So this is how the IDSP works. They try to collect information. Once information has been collected, it is passed on to various levels. It may be passed to the PHCs, it is passed to the district surveillance unit, it is passed to the state surveillance unit, and also to the central surveillance unit. So right now for COVID-19, the action is being taken by all these levels. Okay, there are some tasks which are to be done by the district surveillance unit, some tasks to be state surveillance units, and some tasks are directly under the central surveillance unit. So that is the importance of IDSP. If there are any further questions, you can WhatsApp me, you can email me. I will try to circulate this latest advisory on the WhatsApp group so that you can have a read on how the COVID situation is linked to IDSP and what are the actions being taken, how feedback would be obtained from these actions, and how fresh data collection would happen. Don't forget the initial slide that I showed you. What is the aim of IDSP? Ultimately, the aim is that data collection should happen. Okay, this slide, data collection should happen, then we can compile that data, we can analyze, interpret, and it should be always followed up with some public health action. Okay, and feedback. So this is what we are trying to do at the point now with COVID-19, and IDSP has a very important role to play because this is one of the viral fever or with hemorrhagic potential or any unknown syndrome, you can say it falls under that category, and it has international attention. So thank you very much. If there are further questions, please do WhatsApp me. I'll try to respond to them. Thank you.